So my name's Robin Haynes. I'm a speech and language therapist at Frimley Health, based at Frimley Park Hospital. And this training today is about dysphagia and managing swallowing risk. So this is what we're going to cover in today's session. What is dysphagia? How do I know if my patient has dysphagia? Why does it matter? What can I do about it? What's my role? Food and fluid modification to manage dysphagia, and the role of the speech and language therapist. So this is a video of the normal swallow. So you can see that the person is chewing, then their tongue pushes the food back to be swallowed, the epiglottis flaps over to close off the airway during swallowing, and the food travels down the food pipe towards the stomach. So what is dysphagia? Dysphagia is a medical term for a problem with swallowing. What causes dysphagia? Neurological causes like a stroke or Parkinson's disease, anatomical causes like head and neck cancer, problems with the gastrointestinal tract, respiratory issues or conditions, and then general frailty and comorbidities. So how do you know if your patient has dysphagia? So they might be coughing and choking on food or drinks, have a wet or gurgly voice when they've been eating and drinking, throat clearing when eating and drinking, change of colour when eating or drinking, so going red or even blue, becoming breathless, worsening chest condition or recurrent chest infection. Why does it matter? So swallowing problems and aspiration. So aspiration is a medical term for when food and drink enters the lungs. So this can lead to chest infections and pneumonia, dehydration, weight loss, low energy or poor recovery from illness, depression, increased length of stay in hospital, or even death. So any patient can have dysphagia, but there are some factors that increase the risk of dysphagia and aspiration. So some things that increase the risk are being dependent for feeding, being dependent for oral care, decayed teeth, more than one medical diagnosis, if a patient is confused, if they're fatigued, or if they have poor posture. So how can we prevent aspiration? Research shows that two of the most important factors in developing aspiration pneumonia are poor oral hygiene and poor feeding practices. So you have a really important role in preventing aspiration pneumonia in your patients by helping them with mouth care and good feeding practices at meal times. So mouth care is really, really important before oral intake, after oral intake, and it's really important to remember not to reuse the mouth care sponges. Just dip them into the water once and then throw them away once you've used it once. Don't leave them in water, and do remember to clean your patient's dentures and make sure that they're wearing their dentures when they're eating and drinking. And do complete the mouth care assessment document in the bedside notes. So this slide is about good feeding practices, and I just want you to think about what's wrong with this feeding scenario. So I'll give you a minute to jot some ideas down. So there's quite a few things wrong with this situation, as you might have noticed. So first of all, the care assistant sitting very far away from the patient. She's not really engaging with him or looking at him. The patient doesn't look very alert or aware that he's being fed, and his food is quite a long way away from him, so he probably can't even see what he's eating. So to give patients a good mealtime experience, first of all, you need to check behind their bed for any swallowing recommendations and check that the food and drink you're giving matches the recommendations. You need to make sure that you're sitting close to the patient, their food is within reach and they can see what they're eating. Also make sure that they've got their hearing aids, glasses and dentures in. Ensure they're alert and aware you're going to start feeding them. Also, it's important to check the overbed signs for any specific instructions about whether lidded beakers and straws should be used or not, as these are not appropriate for every patient. So next, I'm going to talk about the role of food and fluid modification in managing dysphagia. So often we will recommend thickened drinks for our patients with dysphagia, and the thickener slows down the speed that drinks move, so it allows more time to coordinate the swallow and reduce the risk of aspiration. And with modified food, soft food with less or no lumps can reduce the choking risk, and chewing can be very tiring for unwell patients, so it might be easier for them to have softer food. And now I'm just going to take you through what we mean by thickened fluids. So there's 4 different levels. Level 1 is the thinnest consistency, so that's 1 scoop of thickener per 200 ml of fluid. And level 1 is thicker than water, but it should flow freely through a straw and run off a spoon. Level 2 is the next thickest, that's 2 scoops of thickener per 200 ml. The fluid runs freely off the spoon but leaves a mild coating. Level 3 is 4 scoops of thickener per 200 ml. The fluid slowly drips off the spoon in dollops. Level 4 is 6 scoops of thickener per 200 ml. The fluid sits on the spoon and should not flow off it, and this is a drink that you can't pour. So you'll see a sign above each patient's bed if they've been seen by a speech and language therapist, which tells you which level the patient requires. So you can see the signs there. They're slightly different for Frimley Park and Wexham Park. So when you're thickening the drinks, make sure that you only use the blue scoop that's provided in the tub. Make sure you use a level scoop, so the level of powder should be completely flat across the scoop. Make sure the cup is completely dry before you add the thickener. Make sure you put the powder in before the drink. Stir the drink thoroughly and keep stirring with a spoon whilst the drink thickens. You need to stir it for around a minute. And the SLT recommendations are based on 200 ml of fluid, and the recommendations are always above the patient's bed. And for patients on thickened fluids, they should not be eating any ice cream or jelly, as the consistency changes and can melt in the mouth, making it too thin. So this is just a note about the cups at Wexham Park Hospital. So red-handled cups to be used for all patients who need thickener, and they shouldn't be having any beaker lids on their cups. And blue lightweight cups are used for those patients who are on thin fluids but need a lighter cup. So this is a slide about our diet options. So we have level 4 puree diet. That's food that's been blended to a thick, smooth consistency with no lumps. It should hold its shape on the plate and be eaten with a fork, and it doesn't require any chewing. Then we have level 7 easy to chew diet, which is well cooked or soft food which doesn't require too much effortful chewing. And then we have level 7 normal diet, and that's foods of all consistencies, including those that are hard, dry, tough, chewy, crumbly, stringy, so no restrictions for those patients. And then at Wexham Park only, there's an additional option of level 6 soft and bite-sized diet. So this is food that is very soft, cut into small pieces, and takes very little chewing. So the food should be moist and served with a thick gravy or sauce with it. So you'll see a sign above the bed which tells you which diet the patient requires. And there's also a coloured tray system to ensure that patients who need help are easily identified. So the red tray indicates patients who need one-to-one assistance to eat, patients who need encouragement and reminding to eat, and patients who need plenty of time for eating their meals. And these patients, their oral intake should be recorded on a food record chart. Yellow trays are patients who need a bit of assistance to set up but can feed themselves independently. So they'll need all their packaging, opening, food cutting up and any preparation that's needed. And then green trays at Frimley Park or black trays at Wexham Park, these are patients who are independent and don't need any support at meal times. So the next part is just asking you some questions about which tray colour the patient would need in these scenarios. So a patient has dementia and is unable to feed himself. The speech and language therapist advises that there's no aspiration risk as long as he has an easy chew diet and can have normal fluids. So does this patient need a red or a yellow tray? I'll just give you a few seconds to jot down an answer. So that one was a red tray. So the patient needs a red tray as he's unable to feed himself. So the next one, a patient had a head injury and is confused. He's being Neil by mouth for a week following an aspiration pneumonia. The speech and language therapist wants to begin some oral intake in the form of puree diet and level 2 thickened fluids under supervision. Does this patient need a red or a yellow tray? So that patient needs a red tray as he needs supervision and close monitoring with oral intake. The next patient has COPD and requires a pureed diet and normal fluids. His appetite is very poor. He is able to feed himself. Does he need a red or a yellow tray? This patient needs a red tray as his intake is very poor, so he'll need encouragement and his oral intake will need recording on a food chart. So now we move on to the key roles of the healthcare assistant. So following SLT recommendations for eating and drinking, checking that when the meal comes, it matches the sign behind the bed to indicate which food and drink the patient should be having. Assisting patients at meal times, being aware of the warning signs of dysphagia. Assisting with oral hygiene and understanding the importance of this. If recommendations are not followed, it is an RL6 incident. Ask the speech and language therapist if you have questions, concerns, or notice changes in a patient. Helping to make sure that the patient has enough thickener on discharge. Helping to ensure that any discharge paperwork from speech and language therapy goes with the patient. So on discharge, the speech and language therapist may provide a discharge letter including our recommendations and some leaflets, so it's important that this goes with the patient along with some tubs of thickener for them to go home with. The role of speech and language therapy in dysphagia management. So our role is to assess the swallow function of patients, to provide advice including advising on risk of aspiration, possible causes of dysphagia, planning for the future, food and fluid modification to minimise risks. To liaise with the ward staff regarding management plans, including the safest consistencies for eating and drinking, things like positioning of the patient and making sure that signs are placed behind the bed to ensure everybody knows the recommendations for the patient's swallowing. To advise on non-oral feeding plans, for example, NG feeding or PEG. To communicate advice to family members and ensure appropriate follow-up is provided on discharge. So now, time for a quiz. So question 1, patients on thickened fluids shouldn't have ice cream. Why? I'll give you a few seconds to write down an answer. They shouldn't have ice cream because it melts to a normal fluid consistency in the mouth. Question 2. Should patients with dysphagia use a lidded beaker? Ideally, they shouldn't, as it gives less control than using a normal cup, and the lidded beaker can make the fluid travel to the back of the mouth too fast and make people tilt their head back, which can compromise the airway. However, there may be some specific patients where using a spouted beaker might be appropriate, but it's always best to check with the speech and language therapist if you're not sure. Question 3. Can a patient with dysphagia have soup? Yes, but this should be thickened to the appropriate consistency if they're on thickened fluids. The soup should be completely smooth for patients who are on a puree diet. Question 4. Patients who are nil by mouth should be given mouth care once a day. Is this true or false? This is false. Mouth care should be completed regularly to aid reducing infection risk and increasing comfort for the patient. And question 5, give 3 examples of the warning signs of dysphagia. So there's lots of different warning signs. These are some of them. Coughing when eating and drinking, persistent throat clearing when eating and drinking, choking, recurrent chest infection, eyes watering or wet or gurgly voice when eating or drinking.